question, or it will be all at the end of the session? All the discussion at the end of the session, huh? Okay. Thank you so much. It was very fruitful. It's time to introduce our next speaker.
Okay. Thank you very much for Professor Pravin for giving us a hope for patients with pancreatic cancers, especially those with locally advanced disease. And now we will go to the second arm of hope, which is the chemoembolization of pancreatic cancer. And may I call Professor Samer Nasser. He will present his talk about TACE in unresectable pancreatic neoplasm.
Good afternoon, everyone. My topic today will be role of interventional radiology, transarterial chemoperfusion, and management of unresectable pancreatic neoplasm. So it's maybe the same idea of another way of treatment for unresectable pancreatic cancers after the lecture of Professor Vadin. So the aim of this lecture is to be oriented by the proposed new line of treatment. It's not actually a new line, but it could be a new adjuvant line of treatment to be used with the treatment of the usual treatment of the pancreatic cancers. To know the technique of the transarterial chemoperfusion and to negotiate if this new line of treatment is applicable to use for the target patients with irresectable pancreatic cancers. So as we all know, the pancreatic cancers is the fourth leading cause of death in USA and Japan. Most of the patients are diagnosed lately when the tumor is unresectable, when it's symptomatic. And the main cure is, or the main treatment is to resect the pancreatic cancer. So when the patients are diagnosed lately, when it's unresectable, this aim of treatment is not clearly used, so we use another way, the systemic chemotherapy. And as we all know, the palliative procedures still has its complications, the systemic effects of the chemotherapy, or another palliative, the complications of the other ways of treatment, so it's still non-desirable. So the idea of the transarterial chemoperfusion, honestly, I took it from our famous Dr. Thomas Vogel. He used it. He made his clinical trial in University of Frankfurt, and he did 2 clinical trials for this idea. The transarterial chemoperfusion, it's a local regional procedure. It provides highly concentrated dose of chemotherapeutic drugs. They mainly used mitomycin C and gemcitabine. It provides a prolonged drug cell contact and it minimizes the systemic toxicity. The main line of treatment now, which is used, is the folfoxir or folfirinox. It's used systemic, but the patient still experienced its side effect, the systemic toxicity and side effects of the systemic treatment. So this, the transarterial chemoperfusion reduces the systemic toxicity and effects of the chemotherapeutic drugs. Its idea is simple. How it's done, it's the same idea like the transarterial chemoembolization of the HCC. We use the Seldinger technique. We access through the femoral artery to the celiac, and we microselect the arteries of the feeding tumor, if it's gastroduodenal or other subsegmental arteries. We then used a chemoperfusion, a perfusion pump of dose of 8.5 milligram and 1,000 milligram for the mitomycin C and gemcitabine for about 1 hour. After completion of the perfusion therapy, we remove the femoral sheath and we'll do a follow-up after 4 weeks. The session, one session is not enough for the patient. at least 3 or 4 sessions should be used to the patient, and each of the session should be 4 weeks apart. The 2 studies which Dr. Thomas Vogel made, one was done at 2003. He made it on 50 patients. 25% of these patients were still alive. A smaller percentage had a better prognosis, and another smaller percentage had a better lifestyle when the tumor-related pain reduced. Still, a percentage did not benefit from the chemoperfusion and developed metastases, but he concluded that the chemoperfusion is a minimally invasive treatment for pancreatic carcinomas, and it could be a potential neoadjuvant treatment before surgery, or it could be used in conjunction with other lines of treatment to have a better benefit for the patient. Another study done also by Professor Thomas Vogel at 2007, he used 40 patients, and also a small percentage, not really small, but it's a good percentage showed good response for this line of treatment. At 2019, another study done in China, which they used another line of treatment beside the chemoperfusion. They used radioactive seeds and another line of treatment, but they also concluded that when it's used as a neoadjuvant, the patient could benefit from reducing or downstaging the pancreatic cancer. That's a sample case. I took it from the site of University of Frankfurt, done by Dr. Thomas Vogel. This is a 56-year-old patient. He had infiltrative pancreatic carcinoma. He also had metastasis, liver metastasis. The advantage of the chemoperfusion, it could also reduce the hepatic metastasis course. So it's used for the pancreatic, irresectable pancreatic cancer, and to perfuse the liver for the metastasis. The same patient, after another session, it's now reduced, shrink it in size, and that's after a 9 month after the chemoperfusion, which showed a complete response. Not all patients as I said, not all patients will produce a complete response, but at least a small percentage will benefit from this. So, in view of this, of the poor prognosis of pancreatic cancer and its poor outcome, chemoperfusion could give a hope for these pancreatic, for these patients to have improved quality of life. It could give them a chance of survival. It could also, at least if it did not treat it or downstage the tumor itself, it could help reduce his pain. Which patients could benefit from the chemoperfusion? Patients with irresectable pancreatic cancer, patients who are not responding to systemic chemotherapy, patients with hepatic metastasis will also benefit from this chemoperfusion. The exclusion criteria of the chemoperfusion: if the patient has diffuse metastasis, widespread metastasis, the patient will not benefit from this. And end-stage patients with ECOG performance scale of 4, the bedridden patients. These patients will not benefit, so it's not applicable to use this line of treatment. So to summarize, this line of treatment, it deserves a chance to produce a clinical trial for it. It's proposed in the National Hepatology and Tropical Medicine Research Institute here in Cairo. So we are still preparing for this procedure to try it in patients with as a neoadjuvant therapy. So thank you for your listening.
Thank you very much, Prof.